Okay, let's get going into chapter 6. It's covering genetics, conception, and fetal development. Okay, getting into genetics, you know that your book goes into a lot more detail about this, has more images, can describe it in a different way. So this is just a summary of it. If genetics is particularly confusing to you, I'd recommend trying to find some videos to help illustrate and explain in even more kind of detailed way so that your brain can kind of hold on to that. But just an overview for us. Our DNA has 46 chromosomes, and they are arranged in 23 pairs. 22 of those pairs are called autosomes, and then one pair is the pair of sex hormones, so the XX or XY. 23, so they're matched in 23s. Half of those come from the sperm and half of those come from the egg, right? 23 from each. And if there's any error in that, then we have different genetic problems sometimes, which we'll cover some of those here in a minute. So the females are always XX. So when they split and you have each egg only contains one of those, eggs are always the X because that's the only choice, right? Whereas XY males, when they create sperm, approximately half of the sperm they create are female and half of the sperm they create are male, so to speak, containing X and containing Y chromosomes, right? So it's the male, the sperm, that determines the sex of the baby. Whichever sperm is successful enough to fertilize the egg, whether it's carrying an X or a Y chromosome on it. We're going to cover dominant and recessive traits here in the next few slides, as well as some of the chromosomal abnormalities. If there's an error in the joining of the egg and sperm and the matching of the chromosomes, this can cause chromosomal abnormalities, and this is a major cause of reproductive loss. So many of our early miscarriages and things are because of chromosomal abnormalities, and the body realizes that whatever the error is not compatible with life, and the mother miscarries. A couple of common chromosomal abnormalities are monosomy, which means there are 45 chromosomes instead of 46, so it's missing one. That's the mono. And trisomy is 47 chromosomes. So instead of pairs matching up together, there was one that had an extra one, like a third chromosome, which made 47 instead of 46. The next thing to talk about when referring to genetics is whether it's unifactorial or multifactorial. And all this means is that if it's unifactorial, it's guided solely by problems with the genes or issues that the genes themselves have passed on. If it's multifactorial, then it also could be influenced by environmental concerns. So my picture in this view is obscuring the little Venn diagram down there a little bit, but you should be able to see in the PowerPoint itself, or you can see most of it to be able to get an idea that multifactorial, it's influenced some by genes and some by the environment. So the genes could be there, but if the environment doesn't produce the exact conditions to express that problem, then you may not see it or you may not notice it. So going back up to unifactorial, a single gene controls the trait for each particular trait or disease. We do have carrier screening available that we recommend for most parents to just be aware of possible issues that might come up. Carrier screening is non-invasive. It's just a blood draw, and it can identify single gene disorders, especially autosomal recessive as well, and things that we don't know we're carrying but could pass to our children, especially if both parents are carriers of it. As you can see in that diagram, if the mother and the father are carriers, then there's a 25% that their child might express the gene in a recessive circumstance, right? So 50% chance that their children will be carriers, just like the parents are, and then a 25% that the child won't be a carrier either. Multifactorial are the most common types of congenital malformations. These can't be really predicted. They can't be screened for because it's not purely genetic, right? The environment plays a factor. Cleft lip, cleft palate, and congenital heart disease are all good examples of this. As we know, some of these can be related to nutritional status of the mom while the baby's developing. Neural tube defects, same thing. Spina bifida and anencephaly, folic acid can really significantly reduce the incidence of neural tube defects when taken, especially before pregnancy begins, because most of the time the spinal column is already fully formed by the time we know we're pregnant. All right, so some of the types of screening. Carrier screening we just talked about. Multiple marker screening as well can detect fetal chromosomal abnormalities. So this is done on the fetus, can be done with ultrasound, looking also at nuchal translucency, and the maternal blood for biomarkers. Alpha fetal protein is one of these. Again, this is done with a maternal blood draw, and we can look for her AFP levels. There's a slide soon about kind of determining what AFP can show you, but if the AFP is low, then we suspect Down syndrome. If it's high, we suspect neural tube defects. Another type of testing is chorionic villus sampling. First trimester, this is done, and it's a sample from the placenta, so obviously this is a little more invasive. Percutaneous umbilical blood sampling can test for fetal anemia or thrombocytopenia or infection, and transfusions, meaning that the circulation is not working as it should to get the nutrients to the baby. All right, here's another view of the multiple marker screening, also called a quad screen. The picture here is actually a triple test, so they've added one other kind of factor for that. I wish my picture wasn't right over the corner of that. But as I said before, this maternal AFP screening is the first row of arrows here. First column of arrows, we'll say. But the multiple marker quad screening tests for AFP, HCG, so human chorionic gonadotropin, which is of course the hormone that your body produces during pregnancy, and that's what pregnancy tests detect, like the urine pee on a stick test. Estriol and inhibin, which can tell us several things. The things that we're going to focus on, though, are this AFP column. And as I said in the last slide, AFP is low in Down syndrome and high in neural tube defects. And you can see some of the differences with AFP and HCG specifically, with things like molar pregnancies and multiple gestations and so forth. A couple of the common trisomies are trisomy 21 is Down syndrome, And I definitely would familiarize yourself with the conditions and the symptoms of each. Okay, these pictures are in your book, so refer to that, especially since my picture is covering part of it. But again, trisomy 21, Down syndrome, some of the classics, physical symptoms we see of that. Very common to have heart defects, mental retardation, simian creases, which is the crease that many of us, if you have that M, I don't know if you, when you were in elementary school, you were like, does your hand make an M and then you're going to get married? I don't know. Maybe that was just me in elementary school. Anyway, we have two main creases. One usually goes kind of out this way and one comes across this way. Whereas in Down syndrome, they just have one crease that goes straight across called the simian crease. Brush field spots are spots in their irises. An enlarged tongue is also one of the common characteristics. Trisomy 18 is Edwards syndrome. And by the way, the numbers here are the chromosome that has an extra chromosome on it. So instead of being a pair, it has an extra one, right? So trisomy 21, the extra chromosome is on chromosome 21, and 18 for Edwards syndrome, and 13, and so on. So Edwards syndrome, they commonly have renal malformations and a large occiput, not compatible with life generally for more than a year. And then trisomy 13, Fetal syndrome, more heart defects, cleft lip and palate, polydactyly, so extra digits, and microcephaly. This is also not compatible with life in general for more than about a year. All right, so testing amniotic fluid, amniocentesis, right? In early pregnancy, they're testing for congenital anomalies generally, and in late pregnancy, they're testing for lung maturity. So they might see, they would get the LS ratio, and if the ratio is 2 to 1, then they estimate sufficient surfactant for the baby to do well outside of the uterus. So they might do this if they think they need to deliver the baby early. They want to see if, for instance, we gave the mom steroids to help develop the baby's lungs. That's betamethasone. We commonly give if the mom is at risk for preterm labor and preterm delivery to help encourage the baby's lungs to develop and to develop surfactant. So might do amniocentesis in that case. Now, as you can imagine, this comes with risks. This image is showing, all the layers it goes through, and if you're puncturing the amniotic sac, obviously you're at risk of a full rupture there, which puts the baby at risk for infection. So infection is definitely a big risk here, but also injury to the baby, injury to the placenta or the cord if you're not 100% sure where you are going, where the placenta is, where the cord is, where the baby is, right? So we are, you have to be really careful with this, and watching closely for signs of a continual leak or infection afterwards as well. Okay. Some other non-genetic factors that can affect fetal development. Mentioned nutrition, of course, maternal conditions. So any health, conditions, health problems that she might be having. But then teratogens also. Teratogens are the term for anything that we are exposed to that interferes with our genetic development or fetal development. Teratogens are preventable, but we don't always know which ones they are, right? There's a classic, if any of you have ever watched Call the Midwife, it's a great show, and it can teach you some things. It's obviously not quite as academic. I wouldn't rely on that to teach you some of the important things and that would help you on your tests and things, but it still can give you some good context. But anyway, so set in 50s England, and they were prescribing medication for mothers for nausea that they did not realize until years later were actively causing genetic defects in the babies that were being born. So this is a perfect example of sometimes things that are even prescribed or thought to be helpful that end up being harmful to the baby. Cigarettes even, they used to think it was good for your health, good for your respiratory system because it felt smooth and could help kind of soothe your sore throat or something. And now, of course, that's totally debunked. So teratogens could come from anywhere. They are completely preventable, but only if we know that they cause problems, right? Anyway, the embryonic period is when a fetus is the most severely affected by teratogens because, again, those early stages, they affect large areas of the body and systems of the body. So they can cause miscarriage if the damage is severe enough. Drugs are definitely one example of this. Basically, they're poisonous, right? So illicit drugs, alcohol as well, and smoking. Infections can cause problems in the fetal development as well, especially if your temperature is high enough, causing issues there. And then, of course, radiation. Okay, neural tube defects. These can be the spina bifida and anencephaly, so anything along the spinal column that are problems with development. So these are the two most common. They are already established in the first 24 days of pregnancy. Okay, so we're talking month 1, before many people even know they're pregnant. This is already, the course is already set, already determined. Okay, so what happens with this, the neural tube doesn't close fully, and it's directly related to the intake of folic acid, which is why in preconception counseling we are very careful to push the consumption of folic acid. Okay, folic acid supplements work. Taking foods high in folic acid work as well. But spina bifida is, of course, where the neural tube isn't closed here in the spinal column and it protrudes from the back. And then anencephaly, the brain did not develop normally. Just kind of skimming this to review, many neural tube defects, up to 70%, can be prevented by getting enough vitamin B9, which is folic acid, every day starting before pregnancy. Okay, so this video is a good one, and I won't show it right now because you probably won't be able to see it anyway, but I recommend watching it and may show it in class as well. All right, speaking of the development of amniotic fluid and membranes. So when we're talking about the membranes, we've got the chorion and the amnion. So there are actually multiple layers of the membranes, the amniotic sac. So the chorion is the membrane that forms the embryonic and fetal portion of the placenta, and the amnion are a second set of membranes that envelop and protect the embryo. This is what forms the boundaries of the amniotic cavity, and it really kind of meets and butts up against the chorion. So these two membranes together make up the amniotic sac, and this is what fills with amniotic fluid. 1,000 milligrams by 37 weeks. They're milliliters, sorry. But there's a variation of this, of course, and there can be complications with it. So, for instance, in polyhydramnios, the fetus is producing too much amniotic fluid. This can be a sign of diabetes, and I'll talk about that with the amniotic fluid here in just a minute. Or a sign that the baby is not able to swallow the fluid as they maybe should normally be able to. So if their GI tract is impaired somehow, that could also be that polyhydramnios is developing because of that. Oligohydramnios means there's too little fluid, so less than 400 milliliters. This can happen with postdates, so the placenta is getting old, or other anomalies that can affect the kidneys and bladder, and or preeclampsia. Okay. Now, speaking of amniotic fluid and just kind of explaining it a little bit, amniotic fluid comes from several sources. Some of it is diffused from maternal blood, so just fluid that's pulled out. But it is also fluid that is secreted by the respiratory tract and GI tract of the baby, and fetal urination. So a big part of amniotic fluid is actually fetal urine, and then they kind of do mock breathing. It helps develop their lungs, so it flows in and out of their lungs, expands alveoli, and helps with lung maturity. So this is why polyhydramnios is connected with the baby's kidneys and possible gestational diabetes, because as you know, taking your med-surg or learning for the first time now, but diabetes can cause excessive thirst and excessive urination. So if the baby is taking in more and more and more amniotic fluid, and then they're peeing more and more and more, the amniotic fluid's going to continue to grow in volume. Other things that amniotic fluid is important for: it helps maintain the baby's body temperature. It helps maintain fluid and electrolyte balance. It's a nice cushion from trauma, right? And it gives some space for the cord to not be pinched. And it's also good for exercise. So if the baby has room in there, they can really kick and move their arms and legs around and kind of spin around and everything. And they're already developing their muscles, their muscle tone and coordination in utero. It also prevents the amniotic sac from adhering to the fetal skin. So what can happen if there's too little fluid, and they can get what's called amniotic bands, and it can wrap around digits of fingers or toes or even entire limbs, and can cut off circulation, and can basically kill part of the body before the baby's born. So it's obviously important to have a cushion between the amniotic sac and the fetal skin so that that doesn't occur. Okay, fetal development. So recommend looking at your book at a nice chart to kind of show you each stage of fetal development and the most critical parts of it. Table 6.1. But important thing that you need to know is that the embryonic stage is through 8 weeks, and this is the most critical time for fetal development and organ system development. All of the major organs and external structures are already formed and in place by the end of the 8th week. This means everything's already formed in its tiny versions of itself, and then 9 weeks and beyond is the fetal period, and this is just maturing and growing each of these systems at that point. Already by day 17 of development, there is already maternal, placental, and embryonic circulation happening. So we have all of the circulatory system already in place for the baby at this time. So things happen very quickly. Again, the first 8 weeks is the time that the baby is most susceptible to errors or problems with development that could cause miscarriage. Excuse me. So that first 8 weeks is extremely important for development. Okay, so some of the specifics about fetal circulation. As I said, by day 17, circulation is established, which means the heart begins beating by the end of the 3rd week. It can be heard externally by Doppler by 12 weeks. You can imagine it's extremely tiny at only 3 weeks, so it needs to develop a little more before we can hear it on Doppler. The ductus arteriosus, which you can see in the fetal circulation chart here, it diverts blood from the fetal lungs. So they do not need the same amount of circulation to the lungs during when they're in utero. So they have these shunts. There are 4 main shunts that are open during fetal development that help divert the fetal circulation in the proper directions in utero, and then after the baby's born, these shunts close to help divert more blood flow to the lungs to collect oxygen from there, and so forth. So in the picture here, you can see a few of these. So you might need to look at your book for some of them to see the full picture. But the ductus arteriosus goes through the aorta there, and it's basically open and it allows some of the mixing from the blood so that you can see it kind of mixes with the unoxygenated blood and gets oxygen to the rest of the body, diverting it again from the fetal lungs. The foramen ovale, some people say foramen ovale, shunts the blood from the right to the left atria. So again, there's just kind of an opening there when the baby's in utero. And then the ductus venosus connects the umbilical vein to the inferior vena cava. And of course, this closes after delivery, after the cord stops pulsating as well, because they don't need the umbilical cord again after that. Things that you should know about the umbilical cord: there are 2 arteries and 1 vein. You can see at the picture at the top, the arteries are smaller and the vein is a little bigger. The difference between adults, well, not adults, but the umbilical circulation and the rest of our circulation, as we have learned, normally arteries are what carries the oxygenated blood, and the vein is what carries the deoxygenated blood, right? But it's opposite for the umbilical circulation. And that's because, again, if we're talking about arteries going away from the heart and veins going toward the heart, in this case, the placenta is actually delivering the oxygenated blood. And so going from the placenta to the heart, it's already oxygenated. So the umbilical vein is actually carrying that, and then as the heart pumps it back to the placenta, so away from the heart to the placenta, it's deoxygenated blood going to the placenta to pick up oxygen. So let me say that again in a hopefully clearer way. If you can imagine the placenta and the baby's heart. So in this case, the placenta is what contains the oxygen, not the heart. The heart is just helping circulate it. So the blood in the placenta has the oxygen. When it goes toward the heart, which would be a vein, it is carrying the oxygen with it. And by the time the heart pumps it back to the placenta, it's deoxygenated blood. So the blood going away from the heart to the placenta is deoxygenated. So the umbilical veins and arteries, again, are opposite of what we think of as carrying oxygenated blood. The way to remember that there are supposed to be 2 arteries and 1 vein is the word Ava, A-V-A. So we can name our umbilical cord Ava. And so we've got 2 arteries and 1 vein. Definitely something that we check with every delivery, that it's a 3-vessel cord. It should be 3-vessel cord, but sometimes there's only a 2-vessel cord, so only 1 artery and 1 vein. So we are checking that. That can show us other signs of problems with fetal development if all 3 vessels are not present. So I'll say it one more time, just for the purpose of repetition. The placenta is what has the oxygenated blood originally, and so when it sends it toward the heart, that is through a vein, but it is oxygenated blood. And then when the heart, after it uses up all the available oxygen, the heart sends it back to the placenta through the arteries, but it is deoxygenated. So it's just opposite of what we think of as, normal adult circulation for as far as veins and arteries go. Okay, quiz yourself on this question. On your own, I just went over that, so just read the choices carefully and see what you think. Okay, so the placenta is the main metabolic exchange organ for the baby. It serves to function for respiration, for nutrition, excretion, and storage for the baby. Okay, placental function is super important, as you can imagine. It's the life organ for the baby, and it's very, very dependent on the maternal blood pressure. So we need mom's blood pressure to be in a safe, normal range. If it is too low, then it doesn't have enough pressure to be supplying blood effectively to the placenta and therefore to the baby. If blood pressure is too high, then it can come with a host of other problems, but in the short term, it can damage the placenta, right? We're causing basically trauma because the pressure levels are so high. And anytime we have damage to the placenta, again, we're not getting oxygen, not getting nutrients, not metabolizing and excreting as well as we should be and could be. The placenta is meant to be a temporary organ. It does have a life expectancy, we'd say. So if the baby goes to postdates and it's getting past its due date, then it starts developing calcifications, the quality starts degrading, and that can interfere with blood flow to the baby as well. They do grade placentas, and they look at it in pathology to see the extent of the calcium deposits and to see what level it is. They can actually grade placentas by ultrasound as well, and that can be predictive of how well the baby's going to tolerate labor as well. So if they have big concerns or if they try labor but things are just not going well because of decelerations of the heart rate, which we'll learn about later, then they may decide to just do a C-section or to deliver the baby early if they have to. The placenta is really amazing. The blood of the baby and the mom never cross, right? They never mix, and it's not the same blood or anything. But it's amazing because there's a single cell layer that separates the maternal and fetal circulation. I'll be able to show you that a little bit more on the next slide. Uteroplacental blood flow increases tenfold during pregnancy, and it also produces hormones in and of itself. It produces progesterone. If you think of the word progesterone, you can think of progestation, because progesterone is the hormone that really encourages our body to hang on to that pregnancy. Okay, so for instance, moms with a history of recurrent miscarriage, so they've had more than one fetal loss or early miscarriage, oftentimes they'll be prescribed progesterone to help tell the body to don't let go of this pregnancy, hang on to it. So progestation, the placenta produces progesterone in and of itself, and it maintains the endometrium. So if you remember, in the menstrual cycle, the endometrium is we shed our endometrial lining during menstrual cycles, and that is what our periods are. So progesterone is the body telling you to hang on to that because we want to support this pregnancy. Okay, so here is kind of a cross-section of the placenta and how it works for exchange of oxygen and nutrients. So the placenta uses active and passive diffusion. And passive diffusion can work for some of the simple gas exchange, oxygen kind of diffusing from high levels to low levels, and fluids as well, right? And you can see, so you can, if you follow, starting at the bottom, you follow the umbilical cord, you can see the arteries and veins, and it goes all the way up into these little kind of tree-looking pods where there's that single cell layer that separates the maternal and fetal circulation. And so there's diffusion happening where oxygen and fluids can freely cross based on the gradient. But there's also active transport happening. So there are proteins, nutrients, all sorts of large cells that need to be actively transported across that membrane, and all those different cells can help with that. But just pretty amazing that it never crosses. And remember, if there is trauma or a chance that the circulation does cross or touch between mother and infant, there are other issues and things that we need to be looking for and taking precautions. You'll hear this a few times throughout the term, but especially if mom is Rh negative, if there's a chance that she's been exposed to her baby's blood, then she'll need to take RhoGAM to protect her future pregnancies. So I'll leave it at that for now. We'll get more on that later. Okay. Now, we touched on this already, but just to get a little more specific on the placenta, it serves for metabolic function by diffusing oxygen across to the baby and carbon dioxide from the baby to the mom's circulation. Metabolic waste products also diffuse from the baby to the mom, and the mom excretes them through her kidneys. Some viruses can cross the placenta to the baby, and as well as bacteria and protozoa can travel to the baby. So certain diseases can be really dangerous for mom and baby. Drugs, of course, can cross as well, including caffeine. If you consume too much caffeine during pregnancy, it is actually in early pregnancy considered dangerous. There's a higher risk for miscarriage if high levels of caffeine are consumed, but it crosses the placenta, so your baby could be born addicted to caffeine if you consume a lot of caffeine during pregnancy. And then we all know that alcohol, drugs, cocaine, the effects of smoking, marijuana, etc., all can cross the placenta and affect the baby. Then the circulatory function. So I mentioned already that the function of the placenta, the effectiveness of it, is very dependent on maternal blood pressure. By the time the baby is full term, 10% of mom's cardiac output is going straight to the uterus. But if there's any interference with the circulation of the placenta, the baby's not getting enough. This can be from vasoconstriction. This happens in hypertension. So we talked about if the mom's blood pressure is too high, vasoconstriction happens, or vice versa, vasoconstriction is causing hypertension. Cocaine use can cause this as well. Hypotension or low cardiac output affects the baby's perfusion, and excessive maternal exercise can as well. All right, practice question here I'll let you look at on your own when you're going through the PowerPoint. Here's figure 611 that has really good outline of fetal development. So you can see in weeks 1 and 2, you've got the splitting of cells and the differentiation going to the blastocyst and starting to develop the amnion and the embryo. The embryonic period is weeks 3 through 8, like we said, and by the end of week 8, all of those major organ systems are already established. So just a really good chart to kind of review and take a look at. All right. Mentioned this earlier. Again, embryonic stage up till week 8, very important for the stage of development. We talked a lot about amniotic fluid already. So we mentioned, I think, all of these already, actually. So just kind of review again the importance of amniotic fluid and where it comes from. Other highlights of development. Around 20 weeks, the mother starts to feel fetal movement, and the term for that is quickening. This term is easily confused with a term you'll hear a little later called lightening. Lightening is when the baby gets engaged in the pelvis. And it's called lightening because it makes her breathing a little easier. She feels a little bit lighter as far as the pressure in her chest. Of course, she might feel a little bit heavier as far as the like bowling ball between her legs now. But quickening is different, and I just like to mention them both now because it can be, I feel like they could be easily mistaken for one another. But quickening, just think of like the baby is quick. It's like running or something. So it's that fetal movement that the mother can feel for the first time. That's called quickening. By 20 weeks, the baby is getting in its favorite position. It has hair on its head, eyebrows, and eyelashes by this point. By 24 weeks, the baby weighs 1 pound, 10 ounces approximately. They're moving a lot more. They begin respiratory movements, taking that amniotic fluid in and out of their lungs. And then by 24 weeks, the surfactant starts developing. 28 weeks, I don't know, I hope I said that right. 28 weeks, surfactant starts developing. 32 weeks, their fingernails and toenails are formed. They start putting on a little bit of chub, subcutaneous fat. They're starting to fill out a little bit, a little less red, a little less wrinkly. And then 38 to 40 weeks, of course, they are fully filling out the uterus, and this is the time period that they get their antibodies from the mother. Another practice question here for you to look at and review on your own, and that is it for the Chapter 6 presentation. Please reach out with any questions, or if you can't find the answer to some of these practice questions, I am happy to hear from you. Happy studying.